Hi everyone, welcome to another Fertility Expert Series Q&A, and I have one of my best friends in the whole world, Dr. Catherine DeUgarte, on. As we wait, there she is. I'm going to bring her on right now. There she is. Yay. Let's see here, Catherine, where did you go? Catherine. There she is. Awesome. Okay. As she's coming on, I just want to read to you this really amazing bracelet that I got. I just got this today, and I absolutely adore it. And I just wanted to read to you what it says. There she is. Hi, Catherine.
Hello. How are you?
I'm good. Who's your special guest there?
I have a special guest with us tonight.
Yeah?
It's Emma.
Hi, Emma. You're so cute. Are you going to help answer some of our fertility questions today, Emma?
She's gonna help answer.
I love it. I love it, love it, love it. So anyways, I was talking about this bracelet, Catherine. I'm sure you get some really cool gifts too. But I got this bracelet today, and it says, every morning you have two choices: continue to sleep with your dreams or wake up and chase them. I think I'll be wearing that for a while. I'll probably wear it until it falls off. And this is another bracelet, a really special bracelet a patient gave me. I told her it looked like blastocysts, and then she got me one too.
That's so cute. It does.
Okay, Catherine, we got so many questions. Are you ready?
I'm ready, and I've got an extra brain with me.
Okay, let's do it. Okay. What's a good BMI for IVF?
So it depends on the situation, but ideally you want to have a normal BMI. If you had to choose between low and high BMI, a low BMI gives you a higher pregnancy rate. Actually, there's a study about this in surrogate BMIs. So ideally you want to have under 25 if possible, but under 30 is okay. Over 35, it's really, really tough to get pregnant.
Yeah, and it's not so much about the number of the BMI either. I think if you have a BMI that's 31, 32, but you have normal blood pressure, your blood sugar is perfect, your cholesterol is great, and you're exercising at least 3 days a week, then, you know, that might not be as bad. But compared to someone who has, let's say, an elevated A1C and high triglycerides, those are the things that you want to treat, right?
Exactly.
Yeah, totally. Okay. Any helpful suggestions for women who have insulin resistance and low AMH? What would you say?
So usually people with insulin resistance have polycystic ovaries, and usually they have high AMH. But if they have insulin resistance and a low AMH, then I'd be more worried about the low AMH, but definitely their hemoglobin A1C should be ideally under 6 before we do a transfer.
Yeah, I agree. I like that number too for a lot of reasons. For those of you who don't know what the reasons are, if your A1C is above 6.2, especially, you might be at high risk of miscarriage and having a baby with birth defects and things that we don't want patients to experience. What kind of supplements or what kind of things do you tell patients to take?
If they're insulin resistant?
Yeah.
Well, we definitely recommend to talk to a nutritionist if they can, and do a diet, low sugar, with exercise, especially exercising after meals, even walking half an hour after meals, I think helps. Sometimes if they are insulin resistant, they need to be on metformin, which is a great medication. I don't like using it if people aren't insulin resistant. But a lot of times I've turned people away from doing a transfer if their hemoglobin A1C is greater than 7, because I think it's too risky, and I make them lose weight and work out and get it under control before they have a baby.
How do you make people lose weight, Catherine? That's mean.
Well, I have a talk with them, and I tell them I've done it and it's possible. And I don't tell them to lose 50 pounds, but I think it's important to even 10 pounds sometimes makes a big difference, and just eating healthy. And it's amazing how bad we all get into habits of, myself, even drinking my chai latte every morning, even cutting that alone out, I think can help. So sugary drinks is like a big first step.
Right. I tell patients that they're allergic to rice and sweets and all those things, and they just can't, eat them anymore. Someone is saying, "Hi, Dr. D, looking great today on the live." That's very sweet. People like you. I like that. That's why you're here. I like you too. Okay. How do you prep? Someone's asking also, how do you prep for the pain of an HSG?
So it's interesting how everybody tolerates HSGs differently. Some people think it's the worst thing in the world, and some people don't even feel it. It's amazing. But I usually recommend to patients, first of all, the place where you go is very important. Because I think there's some places they do a really good job, and they take care to really talk to the patients about what they're going to feel, and they're really gentle. And there's some places that people have horrible experiences in. So I think that that's number one. Number two, I do recommend, if they're not allergic to Advil, to take 600 milligrams of Advil about an hour before. And then sometimes I do prescribe Valium in some patients who really can't tolerate procedures very well.
Well, I think I'm nicer than you. I recommend Valium and Tylenol with codeine to everybody. because
you don't let them drive.
No, they're not allowed to
Okay.
drive. So,
Yeah.
so the thing is that, you don't know who's going to show up for your HSG that day. If it's someone who has lots of experience with the cervix, if people, it might take them a while to kind of figure out exactly the angle. I mean, you and I can get an HSG done in like 5 seconds or less. Right. But yeah, so I agree with you. Definitely recommend at least Motrin, if not more, but that's what I say too. Okay. Here is a question that someone sent us about the egg freezing process, slow freeze versus vitrification. I'm going to read her question right now. 13 years ago, when I was 21 years old, I was diagnosed with Hodgkin's lymphoma, and before starting chemotherapy, I decided to freeze my eggs. I had 19 eggs frozen using the slow freezing process. I'm now 34, and my husband and I have been trying to conceive for over a year and a half. We tried 2 cycles of timed intercourse and 3 cycles of an IUI, and all failed. I was recently diagnosed with PCOS, and I'm being treated with metformin, and we've decided to do IVF. My question is this. I've been told that my previously frozen eggs may not be the best due to the way they were frozen 13 years ago. Would it be better for me to do a fresh cycle of IVF or use my pre-chemo eggs that were slow frozen when I was 21? I'd like to know on average how many eggs are usually retrieved during a fresh cycle. My AMH is still pretty high.
So that's a really good sign that her AMH is so high. I would first ask how many kids they want to have.
Right.
That would be my number one question. If they want to have 1 kid and they don't want to go through another retrieval, they could try to unfreeze the eggs that were frozen. However, I have noticed myself, because when we first started doing egg freezing, the slow freezing process, they don't result in as many embryos as the vitrification embryos or eggs. So if they are slow frozen and she does have a high AMH and she does want to have another baby, I would say leave those alone for baby number 2 and do another cycle. Now you should have some eggs with such a high AMH level.
Right. You said something to me the other day when we were talking. You came up with a really cute analogy. What was it? I think it might have been this morning. Take some eggs.
We talked so much.
An egg race. You said like
egg race.
Oh,
my egg race. Yes, my patients that have used their frozen eggs versus their now eggs. So the older eggs versus the older eggs. You could, but she has a lot of eggs. You don't need to. But if you only have 6 eggs frozen, you could do another cycle and unfreeze them the day of their egg retrieval and do the egg race and see which ones does better.
Yep. Love it. Okay, here's another question. I want to know why some doctors prescribe clomid from days 3 through 7 and some 5 through 9. Is there a reason?
Yes. In fact, when I was a medical student, we would prescribe clomid to everybody on day 5.
Yeah.
And the way we would remember it, it was like 5 days of meds, 50 milligrams for 5 days. 5 days later, they have sex. And then 5 days later, they ovulate. So it was easy to remember. So then somebody came along and started recommending on day 3, and the only reason that is that people ovulate 2 days earlier and they have their babies 2 days earlier. So that's the only reason. So you can actually start day 3, 4, or 5. There's no medical benefit.
Well, some people say you pick the egg you're going to ovulate by cycle day 5. So if you start earlier, there might be a benefit. But I agree. Like I tell patients, like some patients forget to take their meds on day 4 or 5, on day 3, and I'm like, don't worry.
Or they don't call you till day 4.
Exactly, that their period. Yeah, we're not going to shame you for that, and definitely try and still get a cycle together. Here's another question. Secondly, would clomid or letrozole make you ovulate stronger? I know I ovulate, however, it's very late as cycle days 23 or 24. Would one of the meds make me ovulate sooner or better?
So when I was in Michigan with Dr. Evazadeh, I actually did a study of clomid versus letrozole. And what I found is that with clomid, actually people ovulated more, but with Femara or letrozole, people ovulated less follicles. So I think it depends on the person. So I think clomid does work better in general from an egg number. However, with Femara, they have less side effects, and it doesn't affect the lining as well.
Yeah, and I think it also depends on the dose of Femara you use. I think a lot of people, especially if they're going to their OBGYNs are well-intentioned, but sometimes they only give them like 1 tablet of Femara, and they think that's taking Femara. But doctors like me and you will use 3, 4, and sometimes they even use 5 tablets of Femara based on the patient's body size and her story too.
In fact, I've had a few patients that I've used the Dr. Amy protocol for resistant patients, that I've used the Femara protocol that Dr. Amy uses, and have had babies when they didn't respond to clomid at all.
Yeah, cool. Okay. Here we go. For this session, could you explain what the trigger shot does in a medicated IUI cycle? Does it speed up the maturation? Also, when should you have sex if you're doing an IUI?
That's a good question. And I do recommend trigger shots from the perspective that my patients are very busy.
Yeah.
And so they like to know when they're ovulating exactly, especially if they're using frozen sperm, if they're using a donor sperm. It's more precise so that, because sometimes when you check the ovulation kits, you're ovulating maybe the next day or the day after that. You don't know exactly. Right. So I think it helps with the timing of the IUI or timed intercourse. Right. And in terms of sex, again, I tell people to have sex all the time when they're not ovulating, but when they are ovulating that day, and definitely the next day. And if they're doing an IUI, I would tell them to have sex the night of after the IUI and the day after.
And do you get the same looks like I get? It's like that, like, what? Because they freak out, like I'm telling them something wrong because they're told over and over not to have sex. And they read that online that they should build up and save up. I'm like, what are you saving for? And then when they do the semen analysis, they're told they have to abstain 3 to 5 days or whatever the semen analysis folks tell them. And I'm like, but that's a semen analysis. That's totally different. We're trying to get pregnant right now. And
I do tell them for 2 days before, if you're going to do an IUI, to abstain, just so we can have a better number that we're putting.
Yeah, I think it depends on the guy's number. I tell everyone, have sex the night before the follicle check. Come in for the follicle check, and then I'll tell you what I think from there.
Exactly.
Yeah, I'll give them the prescription for sex. Okay, here's another question. Hello, Dr. Amy. Thanks for this Q&A session. They've been very helpful. I want to ask both you and Dr. Catherine, which protocol would both of you use for a woman with a normal cycle while doing a natural FET, skipping the ERA test? I want to know what your protocol would be. So what would you do? How do you run a natural cycle FET?
So usually, I don't do as many natural as program cycles, but for the natural cycles, for people who can't tolerate estrogen, for example, we let them either ovulate on their own or do a trigger shot. And then 2 days after the trigger shot is the date of quote unquote ovulation. So if they don't want to get pregnant, I actually had a patient who got pregnant with a follicle that ovulated and the embryo that I put in. She had twins, so that can happen. So if they don't want to get pregnant with their eggs that are not tested, then they shouldn't have sex if they have ovulation. And then the transfer happens 5 days after ovulation, so 7 days after the trigger shot. And then I usually do recommend some type of progesterone 2 days after ovulation, either vaginal or shots, to basically improve the chance of getting pregnant.
Yeah, we do the exact same thing. Just lots of monitoring, just more follicle checks, usually blood draws, just to make sure we got it just right for that trigger shot before the transfer.
Exactly.
And then she asked, would you transfer on the 6th day or the 7th day after the trigger shot? And it seems like you and I are the same. We would both transfer at 7th day, assuming the progesterone level is nice and low. But if your progesterone's already rising, maybe a doctor would choose 6 days after. But we like to make sure that everything is we like to be ahead of things. Okay, here's another question. Hi, doctors. We just had our retrieval yesterday. Yay, I've been prescribed Dostinex and Letrozole, 10 milligrams for my prevention of OHSS regimen. When can I expect to have my period?
I think your period's going to come regardless of those medications. It usually comes 10 days after retrievals, and sometimes earlier, sometimes later. But usually within 10 days, and obviously the period's going to be, like you called it, very heavy.
Like a waterfall.
Like a waterfall. I like that.
Better than saying the other thing that I said.
Yes, exactly.
A waterfall. Okay. So now the other question is, what can I ask the embryologist regarding my embryology reports?
Well, usually the embryologist won't talk to the patients directly because they're very busy. So that's why we actually talk to the embryologists about the embryos. But we actually ask them about the quality of the embryos, and they grade them depending on the lab. They have different grading criteria. So in our lab, for example, a grade 1, and with low amount of fragmentation, that's considered grade 1. And then they look at the type of embryo. So an expanded blast grade 1 would be the most beautiful type of embryo somebody could have.
So in some labs, I heard even like a medical assistant or a nurse calls. And in some labs, sometimes it's the lab director that calls the patients. But
I like to call my patients with
me
the
too.
Information because they have questions.
Well, absolutely. And sometimes people, they don't have the same background that you and I have as far as the experience of what to expect from there, and that's just not fair to a patient who's been through so much. Okay, here's another question. Thank you so much for your live tonight. I'm 31 years old with PCOS. I recently did IVF. 11 eggs retrieved, 9 fertilized. I did not do genetic testing. I did a fresh transfer of two 4BA embryos. The transfer resulted in a chemical pregnancy. I'm preparing for an FET now and would like to know if there's anything I should do differently. Here's what my clinic suggested. Lovenox, aspirin even after a positive pregnancy test. I'm just so nervous about it resulting in a chemical again. If this transfer fails, I'm considering doing another round of IVF with CoQ10 and ovasitol. I'm concerned about the egg quality of my embryos, as 4 of the remaining embryos were morullas that turned into 2 cc embryos on day 6. Thank you for taking the time to answer this. What would you do, Catherine?
So I would just give Lovenox without a workup. I would want to do a workup to see if somebody does need to do Lovenox, but if just one chemical, I probably wouldn't do that. However, I would want to make sure that the uterus was evaluated, make sure there's no polyps, no fibroids, make sure the person has had a sonohystogram or an HSG within a year. The other thing is I probably would do now an ERA and a Recitiva test just to make sure that there's nothing else going on, given that they've had the miscarriages. And then I usually do aspirin for most of my transfers regardless. I think I stopped for a little while during COVID just because of some studies, but I resumed that.
Yeah, I agree. I now have everyone on aspirin, especially because there was a recent study that I just got, one of those journals that was on my desk, showing that women who started aspirin before 11 weeks might have a decreased risk of preterm labor, and then after 11 weeks, decreased risk of preeclampsia. So it seems like,
so I think it's good for the
and then in this particular patient, I just thought one thing, for patients who choose not to do genetic testing of their embryos, because chromosome testing is so cheap now, it's about $350 or so to get a karyotype. Make sure that the reason why the biochemicals isn't because you or your partner might have a structural rearrangement like a translocation, right? So getting a chromosome analysis, and making sure you've done enough genetic screening ahead of time would be really important. Okay.
And then the type of progesterone too, I would make sure that she's adequately progesteronized, so enough progesterone, like shots versus vaginal, I think would help.
I agree. Okay, here's another question. Can fertility continue to be intact after having 2 abdominal myomectomies due to uterine fibroids?
I have had patients who've had 2 abdominal myomectomy or more and have had babies. With that said, we obviously want to make sure that there's no additional fibroids that could be blocking pregnancies or causing miscarriages. And then we'd want to make sure we do a sonohystogram before the transfer happens.
Yeah, I agree. And just making sure the fallopian tubes are open. When you've had abdominal myomectomies, you might be at risk for a hydrosalpinx, and that can kind of get in the way of a successful transfer and maybe put you at risk for an ectopic pregnancy. So Catherine and I know we both look at that by doing an HSG before we transfer in cases like that. Okay, here's another question. Doctors, love you both. Love you, Catherine. Okay, I tried for almost 2 years. Where did Emma go, by the way?
Oh, she's took a little break.
Okay. She's studying a little bit. She's studying a little bit before the next set of questions.
Exactly.
Okay, cool. I love your lipstick, by the way.
Thank you.
It's very pretty. And your eyebrows look awesome.
You're so cute.
All right. I tried for almost 2 years to get pregnant with my child. My AMH in 2016 was 5.7 at 25 years of age. We did 4 rounds of clomid, a trigger shot, but got pregnant without any treatments 3 months after stopping all fertility treatments and had a healthy pregnancy. We're now trying for our second, got pregnant the first month, had a miscarriage at 8 weeks. We've been trying for 7 months after the miscarriage, no luck. I started ovasitol per my acupuncturist, vitamin D3, ubiquinol, pterostilbene, acai berry, melatonin, and fish oil. Is there anything else I should be doing to increase my chances?
And how old did you say she was?
Well, it seems in 2016 she was 25 years old. So quick math, she's about 29.
29. So she's very young still.
Yeah.
I would want to make sure that we look at all the things that you want to look for before you get them pregnant, such as semen analysis and an HSG. And exactly, all those. Uterine factor. Oh, I love the cup. I need one of those.
I know, it was a gift.
That's
Get your tushy checked, tubes, uterus, sperm, hormones, your genetics.
Except for it's backward on
I know, it's backward. And I just found this new company, Meet Fellow, MEETFELLOW. And if you use the code Egg Whisperer, they'll give you a discount. No money comes to me, although they should pay me. I'm just kidding. But it's a home semen analysis. And it looks at motility and morphology.
And is it accurate?
Yeah, it's validated. 189 bucks.
Oh.
Results within 24 hours. So that's one thing I think this inquiring mind should do is check sperm, look at fallopian tubes. Just because you got pregnant with the first baby in the uterus doesn't mean both tubes are open. So get your tushy checked, right?
Yep, absolutely.
Yeah. And we spend so much time on supplements. You got to make sure the other side is on supplements too.
And a lot of times men will take supplements. I've had that happen to me. He was taking a patient was taking testosterone without telling us. The day of the retrieval, he had no sperm.
Totally.
And we were not very happy because he was kind of hiding it.
Yeah,
So,
that makes me a little bit upset. That's slightly annoying. We call that a sperm emergency. We don't like sperm emergencies. We do not like sperm emergencies. Okay, Catherine, are you ready for all the questions that we're getting here right now? Rapid fire, here we go. I'm just going to go to the beginning, and we're going to have some fun answering everyone's questions. Thank you, everyone. We love answering your questions. Catherine and I have a blast doing this, so thank you. Okay, here we go. What advice would you give to someone who is above 40 still trying to conceive?
So above 40, still trying to conceive, depends again, how many babies. I think that's super important. If you want to have one baby, I would want to make sure they get tested for their fertility, their AMH, E2, FSH, your Tushy method. Make sure everything looks good. And obviously sperm test, because especially after 40, if you find out that the guy has low sperm, in 6 months later, you've wasted 6 months. Absolutely. Same thing with the fallopian tubes. I would want to get checked, not right away if you've been trying for 2 months, but at some point to make sure the uterus looks good in the tubes.
Yeah, I think especially if you want more than one kid, no matter how amazing you look on the outside, your ovaries are still 40 years old. And if you want 2 kids, you want to be your own egg donor. So get those eggs frozen, get those embryos frozen.
Autologous egg donor.
Yes, exactly. That's what we call it. So I tell my patients who are over 40, be as aggressive as you feel comfortable being. And that could be just taking medications to help you ovulate more eggs, but definitely do all the routine screens and don't wait to see one of us. And just seeing one of us doesn't mean you have to do IVF. It just means learning more about your body.
Right.
Okay, so here's another question. Do the embryologists disturb the embryos by doing the reports and day-to-day checks?
It's a good question, and every lab is different. Our lab doesn't check them on day 2. They check them the day of fertilization, which is considered day 1. They don't check them day 2. Then they check them again on day 3, and then day 5 or 6 when they need to biopsy them or freeze them. Right. So we don't actually disturb them every day. There's some new technology where you can actually look at embryos with a camera. I think it's a little bit overrated. I haven't been super impressed with the studies from that. It's kind of a cool technology that they have 1,000 pictures. Who knows if that's good for them or not? But that way you don't disturb them. But I don't know if thousands of photo shoots are any better for them.
Yeah, good point. Okay, are ERAs necessary for women who've been pregnant with timed intercourse before?
So again, I think we differ here a little bit. I don't do it for everybody before their first transfer, but some doctors do. So I don't unless they've had a failed transfer personally.
Yeah, and if you've had a previous pregnancy, that doesn't necessarily mean that we know the right protocol for you during a frozen embryo transfer. So frozen embryo transfer protocols, especially when they're controlled, are very artificial. We're mimicking what we think your body needs, and that's why doing the ERA tells us exactly what your body needs, because we can't see that on ultrasound. A previous pregnancy wouldn't tell us that. Okay, here's another question. Hi, doctors. Okay, what comes to mind when hearing of a 28-year-old with an AMH of 0.089? What are the causes, and thank you?
So I actually had a patient who had a very low AMH, and she ended up having 30 eggs. So that's very unlikely, though. But if the person who has low AMH has a lot of follicles, I kind of disregard the AMH. But if the person who has a low AMH has 1 or 2 follicles, then that's concerning. And I would recommend, honestly, number 1 recommendation, if she was my sister, I would say just get pregnant. Yeah. If she wanted to have 2 kids, maybe freeze some embryos or eggs before getting pregnant, because you don't want to wait for it to drop. But if there's a lot of eggs, you should be okay.
Yeah, and with a 0.08 AMH, I'm thinking check a chromosome analysis, do a Fragile X screen, look at autoimmune issues, look at anti-ovarian antibodies, and it might take even 3 to 6 tries to get a healthy embryo, but I think it might be worthwhile doing it while you still have, cycles. Yep. Okay, here's another question. When doing a medicated FET cycle, when do you transfer? Ant flow was 13 days ago, and I have a lining check on Monday. So what cycle day, Catherine, typically do you do your transfers?
So I usually do transfers around day 21, day 1 being the day that I start the estrogen pills. So usually 3 weeks after we start the medications is usually when I do the transfer.
So the same person who asked us about Dostinex and Letrozole is asking a question again. Would the Dostinex and Letrozole delay the period at all? I need to take them for 10 days, and I haven't noticed. I mean, I use Dostinex and Letrozole a lot after transfers, and I don't notice that it really delays it much, if at all. Okay, as far as aspirin, what do you recommend? Any brand of aspirin or baby aspirin?
So any brand is fine. I usually recommend baby aspirin, the 81 milligrams.
Yeah, I like the baby aspirin, and I like prescribing it to patients because the tablets are so small when they're prescribed. If you get it from the if you get it over the counter, like you would get Motrin, for example, the tablets are bigger. And so when you're already taking so many pills, it's really nice to get something super tiny. Okay. How do you feel about embryo transfers without medications? And we kind of already talked about our protocol, and we kind of talked about what we feel about that. So I'm going to go to the next question. What can happen, or what are the possibilities of getting pregnant with PCOS and your partner having 0 sperm after a semen analysis?
So if it's 0 sperm, doesn't mean that there's 0 sperm. There actually could be sperm. It just doesn't have an exit route. It basically could be there. There could be an anatomical defect where the partner would need a sperm retrieval. So they would definitely need to see a urologist, get a workup to see if there is sperm. However, if there is sperm in the testicles, the only way we can get that person pregnant is by doing IVF, because that sperm is immature, so insemination would not work.
Yeah, I talked to Dr. Spitz yesterday.
I saw that.
Author of the Penis book. He's a great guy. I use there are 3 urologists up here that are great: Dr. Smith, Dr. Turek, and Dr. Pan. So I'd have you see that one of my sperm guys over here. Okay, here's another question. She calls it weird. I like weird questions. Weird question: does cosmetic enhancements such as Botox or fillers impact egg quality, or are we advised against using them while prepping for IVF? What do you say?
Well, living in LA, that's actually one of the top questions I get from my patients.
Yeah.
Besides, can I have sex?
Right.
So those are like the top 2 questions.
Right.
Oh no, hair dye. Hair dye is the third one. Sorry. But in terms of Botox, there's no studies. Unfortunately, there's no randomized studies about people receiving Botox. I definitely don't recommend it in pregnancy, just in case there's a reaction. But I think before you're doing treatments, I think it's fine to do, or fillers. But obviously, make sure you do it with somebody who's good, who you trust. Right. Because you don't want to get an infection from the needle or anything like that.
Sure, I agree. Botox is fine. I don't think it affects egg quality either. Okay, why is PIO, so progesterone oil, better than vaginal for FET? Why do you say it's better, Catherine?
Well, first of all, there's been studies about comparing the two, and they've shown an improvement. And also from personal experience, I think both Amy and I have a lot of experience with cycles of people doing vaginal and then switching to shots and making it work. So I do think it's stronger. So I leave it up to my patients, but I do strongly recommend the shots over the vaginal because I do think it gets absorbed better. Right. And I think it just works better. And also with the vaginal progesterone, a lot of people have spotting. And so when you have spotting, the vaginal progesterone doesn't get absorbed. So it's like a big vicious cycle. So I think if you have a lot of embryos, if you have 10 normal embryos, which is very unlikely, you could try vaginal progesterone because you have more to play with, quote unquote. Right. But if you only have one golden embryo, then you want to give it all you've got. You want to give it, the Rolls Royce of progesterones.
Yeah, and when a patient of mine chooses vaginal progesterone, I mean, there's a lot of discussion that goes into it. It's like you skip one, our efforts are done. It has to be 8, 2, and 8. Never more than 12 hours will elapse between your last one and the first one in the morning. So don't call me that you slept in at 11 and missed that 8 a.m. And then I check the heck out of your progesterone. I have goals. I want a progesterone level that's over 8 at least if vaginally absorbed. If it's not, we go to 4 times a day, 8, noon, 4, and 8. And then if it's still not, I'm going to check you again. If it's still not where I want it, then you're going to add an oral capsule every single night before you go to sleep. So it's a lot more work, and there are patients that just want to do that, and I'm totally fine with it, and the outcomes I think are pretty similar. Because some people just can't tolerate that shot. They get the worst reaction from it.
And some people prefer it. Actually.
Oh, some people do. Oh, yeah. No, I mean, I've even had patients who do IUIs that don't want to do any vaginal progesterone. Right. They don't want to take, they just want to do, they're like, why would I do that 3 times a day? That's gross. But some patients, it's not so gross for them. Okay.
And it's less expensive too.
The shot is less expensive. That's true. Yeah. I totally agree. Okay. Hi, doctors. I was told by one doctor that priming with birth control for 8 to 12 days will allow more follicles versus if I were to have no priming, this doctor said I would only get 1 follicle. What do you think?
I think not, but to be politically correct, I'm not a big fan of birth control pills unless people want to use it for timing. Right. And if you are going to use birth control pills, I think you should use it for more days, like at least 14 to 18 days, because otherwise you're just going to have spotting all the time and it's going to be confusing and it's going to be annoying. Right. So I don't think you're going to have more follicles. I think the doctors probably just wants to do it because of doesn't want to do weekend procedures, and they do it for timing, honestly. A lot of places do that, and I understand, because if they don't have their lab nearby, you want to batch cycles, or people are busy and they can only do it. But I'm not a big fan of birth control pills for everybody.
Me neither. And she also added that her AMH is 0.5 and she's 40 years old. So you
definitely would not even add. No. I actually don't like birth control pills, especially after 40, and especially if they have low AMH.
Yeah, I mean, if you have a ton of eggs, like if I'm getting 25 to 30 eggs from you, then birth control pill is not a big deal, but very rarely does a 40-year-old have that. Okay, what percentage of day 1 zygotes usually makes it to day 5, day 6 blast? I was told I would get a day 2 report. Should I be worried?
So I think it depends on the age and depends on the lab. It depends on how many they start with. It's very all over the place, but I usually say the 50-50-50 rule. So if you start out with 10 eggs, you might end up with half that make it to maybe day 3 and half that make it to day 5.
Yeah, I like that. Half of a half of a half of a half. Okay, what do you recommend for a poor responder to increase chances for more eggs retrieved? Diet and exercise recommendations, supplements?
So we talked about supplements last time, so we have a whole list of supplements that you and I recommend. In terms of exercise, I don't recommend more than 3 hours of cardio per week, because I think that's too much for patients. So in terms of exercise, I prefer yoga and Pilates over spinning, for example. And in terms of diet, I think that's very important to eat lots of fruits and vegetables and healthy eating, more organic products if possible, less carbs, more protein, and just have a healthy lifestyle.
I agree. Okay, someone with an endometrioma removed but doesn't have endometriosis. For IVF, would you suggest a long or short protocol? What would you do?
Most people, I start with a short protocol. Just I think it's less shots, and also if they're older, more eggs. But some people I do convert to Lupron protocol if they only have a few follicles or a few eggs or discrepant follicles from the antagonist protocol.
Yeah, I agree. Okay. Do you do anything extra specific for PCOS patients that don't ovulate for IUI and IVF?
So if clomid doesn't work, then I move on to shots and I just monitor them very closely. Sometimes, actually for these type of patients, I found birth control pills sometimes are beneficial to kind of just quiet their hormones down. So sometimes I'll add that for a month before starting medications, and sometimes that helps.
Yeah, I agree. And I think with the birth control pills, it lowers the testosterone level. I think having a normal testosterone level is really important, and normal vitamin D, normal A1C. And a couple of things that I've noticed that can help some patients with PCOS, adding supplements like ovasitol, lipoic acid, and acetylcysteine, metformin if needed. Sometimes even like a short course of birth control pills with spironolactone for a while, and then recheck the testosterone, make sure it's normal before we start meds. And some of the tricks that I've also used are dexamethasone in the morning until trigger shot. And then also naltrexone also might help patients with PCOS if they're super resistant. Those are some of the tricks that I have up my sleeve. And one thing that I did recently is 10 days of Femara for an IUI patient, and she responded, and she had very little response in previous attempts.
Interesting.
Okay. Here's another question. This is a good one. I'm a patient with uterine didelphys. My FET is scheduled for my left side of my uterus next month. Is it possible to still have a monthly cycle in my right side?
So if it's scheduled, then you're on estrogen, you should be ovulating. But if you're not taking estrogen, you could be ovulating on the other side. So I would choose to do the transfer on the side that's the larger cavity. And I'm hoping that doctor did do a sonohystogram to make sure both cavities are good. And if they are trying to do an insemination, not a transfer, we want to make sure that they're ovulating on the correct side. Because if you have a right ovulation and you're putting the sperm in the left tube, they're not going to find each other.
They will have a very hard time finding each other. That is true.
Exactly.
Very, very hard time. Okay, this is a great question. Do small testicles play a role in low sperm quality and quantity?
Well, size is not everything, but if some people have small testicles, the volume, which is what urologists measure, and they have special tools to do that, can indicate that there's less sperm production, but size isn't everything.
I agree. Size isn't everything, but get some stuff checked. Get a testosterone checked. Do a home semen analysis. They're so easy to do nowadays. Okay, here's another question. Oh, actually, not a question. Everyone likes our eyebrows. Okay, we got a comment about our eyebrows. Okay, is the 2-week wait overhyped? Should I go to the office? What do you tell your patients?
Well, it's funny because I had a patient who had some spotting yesterday and came for her pregnancy test today, day 8, and she's pregnant. So it depends. Sometimes we do the pregnancy test. I do it 10 days after the transfer. But obviously if they have spotting or they're really worried about their levels, I sometimes do it, and her level was 200 today. So so now she's gonna have a great weekend.
Yeah, awesome. Yeah, I do an 8-week test for everyone just because I'm impatient. I'm the most impatient person in the whole entire world. So yeah, I mean, it's just so hard to wait those 2 weeks, just so hard. But I know a lot of doctors, but there's still people out there that make their patients wait 2 weeks. I don't know how. I'm just too anxious. I tell my patients, I would go to your house and find you and draw your blood if you made me wait 2 weeks. Okay, here's another question. Would someone with poor morphology motility consider sperm retrieval? And if not, would you suggest MC over ICSI?
So I wouldn't do a sperm retrieval just because of low motility or morphology. I would still try ICSI first because it's less invasive and it usually works. Only for people who have close to 0 sperm would that make a difference.
Yeah, I mean, I love the DNA fragmentation test, so I almost do that on everybody. And if you haven't heard of my balls method, I have the balls method too. I do. So that's just an approach to guys' care, you know, just making sure you haven't missed anything, and doing the DNA fragmentation test is part of that. And if the DNA fragmentation is super high and after lifestyle stuff, and if there's no varicocele, then maybe an aspiration would make sense in certain cases. But I agree, trying ICSI first does make sense. Okay, with IVF, does the retrieval and embryo transfer happen in the same cycle?
So it used to, when you and I finished residency, we used to do fresh transfers on everybody. We rarely did frozen embryo transfer. In fact, when I moved to Michigan, I don't think we ever did frozen embryo transfers initially. But now we do mostly frozen embryo transfers because the technology has gotten better and people feel better. They're not so hyperstimulated with medications and they just feel a lot better and they're lower chance of hyperstimulation syndrome.
Right, I agree. Case by case, but I agree. Okay, how much CoQ10 should a woman take who is 39 before IVF? I've never been pregnant and I've had both tubes removed due to hydrosalpinx. My AMH is 1.2.
So obviously this a person would need IVF because of the tube situation. But if they wanted to maximize their egg quality, for CoQ10, I usually recommend 600 milligrams per day. It depends on the brand because there's a more potent version. Then that one's half this amount.
Yeah, so I think so Theralogix has a version. It's called NeoQ10. It's about 150 milligrams of CoQ10, but it's equivalent to around 700 because of how it's compounded. And they gave me a code. It's Tushy, capital TUSHY, for anyone who wants to go to Theralogix website and get those supplements. Okay, here's another question. Does Provera interfere with trying to conceive? I'm taking it because of PCOS and irregular periods.
So Provera has been shown in some rat studies to be teratogenic. So I actually don't like using it. I rarely use it unless they're postmenopausal patients. Plus it causes more side effects than Prometrium. So I would use Prometrium because it's less teratogenic and the side effects are better. In case you get pregnant with Provera, it's not as safe.
Yeah, so you can still get pregnant. With Provera, it just induces a period, and then sometimes you ovulate and can get pregnant. But I agree, I prefer no Provera. Okay, here's another question. I have both tubes blocked and had a pregnancy from my first IVF cycle, but I miscarried. I hate that. I've done 3 other IVFs. My doctors have stated that I have poor egg quality. Can my tubes be leaking fluid? Is the question.
So the question is, has this person had an HSG? Because I have seen it before with quote unquote blocked tubes, that sometimes one reopens. There's a fistula. And so maybe it would be worthwhile to repeat an HSG to make sure that they truly are blocked. I think that would be a good thing. And also to make sure there's no polyps, and obviously do a further workup to make sure there's no other blood issues, or the sperm test, sperm fragmentation tests in these patients are also very important to do.
I've seen that too, a fistula once. I mean, I was shocked, but I looked for it. I was wondering what the heck was going on. Okay, what is the preferred AMH range for a 29-year-old? Or what about 30-year-old?
So anything more than 1 is good, but obviously 2 to 3 is great. Anything too high, like 9 or 10, makes me think that that person may have polycystic ovarian syndrome and might be more difficult to get pregnant.
Right. I agree. Yeah, I mean, as far as these levels go, I find that they can be inaccurate. You taught me always mean hormone is what the AMH is.
Mean hormone.
And I've seen patients, they get an AMH done, they just assume that they're quote unquote fine, but then they learn once they come in for an ultrasound that their follicle count is a lot lower and they repeat the AMH, that's totally different. So it's super important to track and trend these levels over time, I think, especially if you want more than 1 baby and don't even have one have one, don't have one yet. So don't make assumptions based on your levels that you keep waiting and keep waiting and keep waiting. I've seen that before. Here's a question. I did the ERA test and iGenomics said the sample was too small. I'm secretly blaming my doctor. Did he do a bad job? How often does this happen?
Unfortunately, that's the worst part about the ERA, that sometimes it does come back inconclusive, which is really awful because then you have to either repeat the test or just do something different. Right. I've only seen one inconclusive one. It was actually my first one that I ever did, because they say to put 3 grains of rice in there, and it's sometimes difficult to figure out what 3 grains of rice looks like in blood. That's rare, and unfortunately, it just happens sometimes. And I don't think it's the doctor's fault. It just happens.
Yeah, and right now, because it's so hot outside, people have to be careful because, you know, if it's exposed to extreme heat, that can also make it inconclusive. So, you know, if you're doing an ERA right now and it's like 100 degrees out, talk to your clinic about making sure they know the right temperature control of the ERA kit so that you don't get a test result like that. I had that happen. I had 1 week. That week, it was like over 110 degrees in my office. Every single patient that week, I had 3 tests that came back inconclusive. And I've been doing the test for years, and I was just so upset. And they're like, oh, yeah, it's because probably the heat on the plane or whatever the ground shipping. Yeah, the heat is what made it happen. So now they gave us instructions as to how to do it differently. So here's another question. Is hysteroscopy advised before FET with a patient that has no polyps? So I imagine they probably did like a saline sono and there were no polyps. Would you still do a hysteroscopy?
I don't recommend doing hysteroscopies if people have a normal HSG or sonohistograms. I only do it for patients who have reasons to do surgery, because surgery is surgery. You could have risks and it's expensive to do, copays and surgery center facility fees. So I personally don't do it. I know some clinics do it in everybody. And sometimes, yes, you kind of find like a tiny little polyp, but would that make a difference? We don't know. Right.
I agree. I mean, I kind of wish I could do it on everybody, just because to look one more time right before the transfer, but you're right, it's just so hard and expensive, and it just doesn't, you know, it's just too much. It's just too much, especially when you have a normal saline sono and an HSG. Okay. Hi, doctors. How big of a deal is endometriosis? I don't have symptoms, but I've been trying for 2 years. Should I get tested or just start fertility treatment?
Well, first of all, you can't really get tested for endometriosis unless you do surgery, or if you do the Resectiva test to see if you have it. So unless people have symptoms such as painful periods or painful intercourse, or if they have endometriomas or cysts on ultrasounds, then I wouldn't worry about it. Some infertility patients do have it, but as long as the tubes are open, I would just not worry about it unless there's all those symptoms.
Yeah, I mean, talk to your mom too, because if mom had endometriosis or sisters had endometriosis, you know, that might be a sign that you might be at risk. Silent endometriosis is really, really common. If it's something that's, you know, that you keep thinking about, I think talking to a doctor to see if you have it or not makes sense. But otherwise, I would just start treatment. But get a diagnosis first. Diagnosis before treatment. And I believe there's no such thing as unexplained. I think the explanation is no one really explained the different explanations to you. Okay, here's another question. Yes. Yeah. I think Catherine's batteries died.
Sorry,
Hi.
I think it
That's okay.
Sorry.
No problem. Okay, I always get a delayed period whenever I spot during the follicular phase. Could this be a sign of PCOS? Spotting starts 2 to 5 days after the period is over.
So that could be more of a sign of a polyp, usually. So to make sure that that person has a fluid ultrasound or an HSG to make sure. Yeah. Sometimes it could also be hormonal. It could be a bad egg ovulating.
Yeah. Or it could just be a sign of a cyst carried over from the last cycle that's hormone secreting, causing a wonky little, you know, wonky stuff going on. And, you know, for us, it'd be like, hey, this is happening. Come on in. I'll just do a quick level check, estrogen, progesterone, do an ultrasound while you're here, and we'll give you a diagnosis. But I know not everyone has access to us.
Yep.
You know, okay. Here's another question. Should I be wary of a doctor that absolutely requires PGT testing and won't allow IVF without it?
I mean, not everybody has to have PGTA.
Oh, I require it, Catherine. If you don't do it, you can't be my patient. I'm just kidding. Of course not. No, you get to have the momlet. I call them momlets. We make momlets every day here. You get
momlets.
You go to the, you know, the egg, you know, like the chef with the eggs and the pans. I like clearly don't cook. And you get to choose how you want your momlet made, and it's up to you. It's not up to me. But if you want to ask me what I think the best momlet is in this kitchen, right?
Yeah,
I'll tell you.
absolutely.
Okay.
And you want to have an excellent experience.
And eggs, absolutely. We can do this all day long. All day long. Okay. Do you recommend 1 or 2 pills of Theralogic Neo Q10? Bottle says to take 1 or 2. What do you tell your patients?
Well, it sounds like 1 is the new formulation that has a 700 in there. You would need to take more than 1 a day.
Yeah, I mean, some patients can't tolerate 2. I think it also depends on the patient's body size, too. So 1 to 2, you know, I tell patients to start with 1, and if they want to take 2, they can. It's just more expensive because they have to buy more. Okay. Someone with 51% DNA fragmentation has had antibiotics and varicocele surgery, not had repeat DNA fragmentation, but due to start ICSI. Would you not continue without repeating the DNA fragmentation? What would you do, Catherine?
So I would definitely want to make sure that they see a urologist to make sure there's no anatomical issues.
Yeah, so they had varicocele surgery. They already had the varicocele removed.
No, but just to make sure that there's no recurrent varicocele.
Oh, yeah, smart aleck. Okay, fine.
And then also to make sure their hormones are intact. Make sure that they're good. And if they've taken supplements and done everything possible, then obviously you just try the ICSI cycle. Yeah. But I don't necessarily repeat it after 3 months of supplements. Sometimes you just go into another cycle.
Yeah, I repeat it because I just feel like if your DNA fragmentation is over 35%, your likelihood of getting a healthy embryo, even if it has normal chromosomes, is really low. And at that point, if you repeat it and it's still over 35%, I would consider doing a sperm or retrieval at that point. And then, you know, I think as women, when we're over 40, women are always told use an egg donor. But sometimes women who are over 40 are, you know, with guys who have high DNA fragmentations, and we're not told consider a sperm donor, so you can still have a pregnancy with your own eggs. So, yeah, I think that that's important. Someone is saying, thank you, ladies, so much for this. You're welcome. Okay. Do ice packs help improve sperm quality? Any proven ways to improve sperm quality to maybe consider sperm freezing? Well, what do you tell patients about ice packs?
Ice packs, 5 hours a day for the testicles. No, I'm just kidding. So no, that's mean. In fact, I think they used to have, I think in the 1960s or 70s, they used to have these ice packs for men for fertility issues. So
there still are. It's called snowballs. Literally, snowballs.
Are they still have that?
Oh, absolutely. So I tell my patients to use it.
I don't recommend icing your guys' balls. I think that's mean. I don't know how many babies would result from that method personally, but definitely don't recommend jacuzziing the balls. Yeah. So just keep them at nice, constant room temperature. That's what I recommend. Yeah, I mean, I have a lot of, with where we live here, there are a lot of guys who drive trucks, truck drivers. And so they're exposed to a lot of heat, especially if they're not in and out of the truck often. And so I sometimes will suggest at the end of the day, ice your balls, get some snowballs in there, or even a pack of peas, or do it throughout the day too. And there's some cars now have ventilation through the seats.
Yes, so and as my April Fool's joke was the testicular temperature tracking system that I came up with Tesla.
Right.
So look at my April Fool's jokes if you guys haven't done it already for a good laugh. Okay, here's a question. Are there any benefits to vaginal steaming? What do you think, Catherine?
Somebody gave me a gift certificate and I've never used it.
Oh, okay.
So I can't tell you that I've tried it.
Yeah.
But at some point, some people recommend that it's very relaxing. Do I think that it improves fertility? There's no studies. Yeah. If it does help you in terms of relaxing you, go for it. But I personally haven't seen any studies on that, honestly. Yeah. And right now with COVID,
you're not going to find anyone that's going to want to steam your vagina with COVID right now. We can't even
go into the steam room at the spa.
We can't even get our nails done or get our legs waxed. I mean, there's so many other things. Okay, but that's a good question. Fun to talk about it with you. Maybe one day when I'm in LA, we'll go use your gift certificate together.
Yes, exactly.
I'm just so devastated. 37 years old, 3 ICSIs, 3 day 3 transfers with only 1 viable embryo out of 7 mature eggs. Will it ever happen? Or should I consider egg donor? The diagnosis was 0% morphology.
So maybe in this person, I would also recommend a urologist consultation and see if they should do a testing procedure. Might help. Maybe the quality of the sperm, definitely the fragmentation test would be important to check. Yeah. I wouldn't give up yet. I would try that first. Yeah. But sounds like they went through a lot, and I'm so sorry. Yeah, I know. 3 cycles of IVF, and to still, I mean, it's just
it's the worst. But obviously our patients are so resilient and so strong and fierce, and they should all get my bracelet. Did I show you my bracelet today, Catherine? Did you see it?
I saw that.
Yeah.
That's
Every
awesome.
morning you have two choices: continue to sleep with your dreams or wake up and chase them. Clearly this woman is waking up and she is chasing them. Okay. Here's another question. Oh, this is the same person who was asking about, should I do a hysteroscopy even though I don't have a polyp? She says, the doctor wants to do a hysteroscopy because he feels he could give me an endometrium scratch and says that doing it will increase my chances for a successful frozen embryo transfer. What do you think?
So the endometrial scratch thing, I think it's been looked at several times. I don't think the scratching part works. I think what happens is people have polyps and they do a hysteroscopy, sometimes they have a higher chance of getting pregnant the month right after that because you've taken out the polyps and you've quote unquote scratched their uterus. But I don't scratch uteruses. Yeah. You know, as per se for everybody.
Yeah. I mean, I do a lot of scratching. And you know why? Because I do the ERA test on everybody.
Right.
I mean, I recommend it to everyone. Probably like 90% of patients do it. And it's basically the scratch. So, I mean, if I didn't do the scratch and their ERA was normal, or I don't know. I don't know that it makes a difference. I agree with you. Okay. So this, so Danielle is saying, hi, Emma.
She likes scratches. She heard scratches.
She's heard scratches. So iGenomics said my sample. So this is back to that, the Danielle who was talking about her iGenomics sample. They did not analyze the sample at all because they said it was too small. They refunded my payment. Is this what you mean by inconclusive? And the answer is yes, right?
Yes, exactly. And actually, they do. They will. ERA company will do it again. Right. They will do another one with no charge if that happens. So, but obviously the biopsy has to be done again. Right.
So if not, she's asking why did this happen? And it could be that the doctor did the right thing, but sometimes we hand off the pipelle to an assistant and maybe they didn't put enough in. And I have, you know, my assistant is like the best when it comes to this. So I'm sure yours, I know yours is too. Your assistants are great. Okay. How soon should you start supplements before a frozen embryo transfer?
So it depends on if the person sees an acupuncturist or not, because sometimes they do recommend wheat germ oil or vitamin E to improve the lining and warm foods. And so I would say as soon as the FET medications start in some patients, if some patients have a very thin lining, then sometimes acupuncturists will recommend more supplements around the time of the transfer, especially right before the transfer.
Got it. Got it. Okay. So we have someone sharing with us that you can do vaginal staining at home. It isn't that hard. Easier if you have a proper stool for it and it feels nice. That's good.
Interesting.
Yeah, that's good. So,
good to know.
Yes. And we're almost done with questions, Catherine. We've been doing this for almost an hour. So we're going to close it off with these last three questions. First question is best vitamins to take during an IVF cycle.
So best vitamins, definitely prenatal vitamins, number one. I would say number two would be CoQ10. During the cycle with medications, I don't necessarily always keep people on supplements. Depends if they're vitamin D deficient, that I do that. So I'd say probably vitamin D would be like my number third.
Yeah, I tell patients to take supplements until they're done doing all their IVF cycles. I don't stop them, but I know some people do, especially if they're worried about bleeding during the egg retrieval. So I totally understand that. Okay, here's another question. Is it safe to drink kombucha and apple cider vinegar with water while trying to conceive and during pregnancy?
I can't tell you yes or no because I don't think there's any studies. I think it should be fine to drink it.
Yeah, I agree. I mean, apple cider vinegar, I just look at it. Have you tried it?
No, it doesn't sound good.
I think when you're pregnant, if you want to drink it, I don't see how it would hurt. Okay. What treatments are available for sperm with anti-sperm antibodies?
So I know in Michigan when I was there, we used to check everybody for anti-sperm antibodies. Here we never check.
Right.
I don't know why that. It must have been a Midwestern.
I think there's more. No, I think in Michigan, in the community that we were at, there's just more male factor for a lot of reasons. So,
but right now we don't even test for it.
And they discovered anti-sperm antibodies in Michigan. It was at University of Michigan where they discovered them. So that probably has something to do with it.
Maybe that's why. Yeah. But I think it's a little bit overhyped, to be honest with you. So I don't really, unless people have had a vasectomy and then they have more sperm antibodies, but otherwise I don't think it's an issue.
Yeah, I agree. And unfortunately, there's not much you can do other than doing IVF. Right. Because I just think of those little sperm cells with a football helmet that's found on there and just so hard for them to penetrate and fertilize an egg, and you just can't peel those antibodies away. Okay, we got a lot of thank you so much. Thank you for answering our questions. And I just want to say thank you everyone for joining me and Catherine. It looks like we put Emma to sleep. Emma looks very comfy right there, right underneath. Bye, Emma. Thank you for joining us.
Bye,
Thank you, everyone, for joining us. Catherine, will you come back on and we'll do this again?
Sounds good. I didn't sync this time.
You didn't sync. You were not in the quicksand this time.
Exactly.
Yeah. Love you. Okay.
Tried.
Bye.
Worked hard.
Bye. Bye. Bye, everybody. Hope you guys join us again soon.
Bye-bye.
Bye, everyone.
Bye.